My talk is on the effect of ancestral diet on cardiovascular biomarkers, but I'm really going to be talking mostly case studies. Carol reminded me this morning that these case studies really aren't for public consumption because the patients will, with a little digging, could be identifiable. So I'm going to do a little beginning and then we'll do the case studies, and I'm hoping that's going to be interactive. And then at the end of the slide set, I put about 70 slides that I had done 2 years ago at this talk about cardiovascular biomarkers, why advanced lipid testing is useful, their validity, and a little bit about how to interpret them. And I'm hoping to be able to clean that up for people so we can give that to other people also. But the case studies we really can't published because of the HIPAA regulations. Case studies. So I've ordered probably several thousand lipid profiles, advanced lipid studies in the past 6 to 8 years. I'm a family practitioner, as many of you know, but I do a lot of cardiovascular work. And unfortunately, much of that is in my in file cabinets on paper and my antiquated EMR. So I was hoping at one point that I can go through all the data and actually make some real information, but I don't know if that's ever going to happen unless somebody gives me money so I can't see patients in the meantime. But I thought I would just do some case studies and show you what you can expect a little bit when you do these studies and when you have people do these diets, sort of real life kind of things. So one of the questions really is, so why do we even care what it does to lipids, to the cardiovascular biomarkers, the dietary changes? So the majority of physicians, such as myself, take insurance. And in primary care, we are judged based on how well we follow official guidelines. Our reimbursement is dependent on these metrics. Guidelines recommend lifestyle changes, but that's just talk in reality. They specifically require patients with certain diagnoses to be on certain medications. And if they don't want to take those medications, where does that leave us? And I'm in a large, loosely organized group. I'm sort of solo, but I'm sort of in a group. And I'm beholden to insurance company rules and metrics. And I am very much scrutinized to follow these current guidelines. Many of my patients come to me, though, because they're very motivated to improve their health via lifestyle, like diet and exercise, and they don't want these medications, which in theory is what the guidelines recommend. But in practice, I actually get dinged mercilessly. LDL greater than 130, why is this patient not on a statin? So what I do as I gather lots of data, and I use it to work with patients to lower their risk of cardiovascular disease. This data motivates patients to take their health seriously and gives them a goal. Sometimes I use the data to convince the patients that lifestyle changes, although they are extremely important, are not enough, and that it may be too dangerous to rely on that alone. And so it sort of works both ways. And since we as physicians are held to a standard of care, we must keep in mind that when deviating too far from this, we are liable not only for malpractice suits, but also losing our license and even criminal charges. So, and that's why I like this organization, because we all understand that, hopefully, at least in this country. So the purpose of this talk is to show what improvements we can realistically expect with real patients by recommending ancestral-type lifestyle changes, and hopefully start a dialogue to allow physicians to treat interested patients with lifestyle changes without fear of economic or legal reprisal. I'm also hoping that those of you who are not comfortable with interpreting these tests will find them a little less intimidating and then integrate them more into your practices. For me, new patient doesn't necessarily mean the patient is new to the practice, but somebody who I feel, who needs a cardiovascular workup. I believe anyone who is at risk for cardiovascular disease deserves a reasonable workup. And the workup for me includes, history, including weight history. I go through excruciating detail with diet. So what did you have for breakfast? What did you drink with your breakfast? When did you eat next? And exactly what is, exactly what they're eating. Because usually when you ask them, how's your diet? They'll say, good. I follow a pretty healthy diet. Lots of whole, then you say, lots of whole grains, fruits, fruits always come before vegetables. What's that? Oh yeah, I don't eat red meat no more than once or twice a month. That's what they consider a good diet. Exercise history, vitals, physical. Anybody who I believe is at risk will get advanced lipid testing with metabolic and inflammatory markers. I'll often do CIMTs on them. I have a low threshold for doing sleep studies on patients. And when saying people who are at cardiovascular disease risk, who are those? Anyone who walks in my office who is on a statin deserves a workup. If they're already being treated for cardiovascular disease, they deserve a full workup. Anybody who has a family history, which I interpret quite liberally, if they have any lipid abnormality, anything, and I'm very either generous or strict, depending on how you look at it, in lipid abnormalities. I don't use the normal ranges that the lab uses. I'm more strict than they are. Anyone who has radiographic evidence of cardiovascular disease. They saw somebody, they had a chest x-ray which showed some calcification in the aorta, anything like that. And any symptoms which potentially could be attributed to it, or anybody who just is worried about their health.
What is CIMT?
Who asked? I'm sorry. Carotid intimal, yeah, medial thickness testing. And actually, I have a couple reports in here. So what follows is a presentation of several patients to show you what you can expect with reasonably compliant patients who have been coaxed to try a lifestyle changes first. These are not necessarily patients who came to me because they wanted to follow a paleo or low carb lifestyle. These are just people who came in because I'm on their insurance. So these are not necessarily my my greatest results, but they're reasonable and fairly typical, and we can often see change in this. And by the way, I'm not going to be presenting every test I did on all of these patients, just the stuff that's pertinent in the and relevant. And again, please, I'd like you guys to ask questions and have this interactive too. Okay, so this is the part where we can't really show this to other people. 43-year-old male, African American, who came in with a headache, and somebody ordered carotid Dopplers, and there was stenosis shown on the carotid Dopplers, which was just an incidental finding. He has hypertension, as you can see, lipids. This is the old cardio IQ, which I don't do anymore. But the lipids, a lot of red on the lipids. Is this working? No, it's all right. That's what.
Kind of pooped out in the middle of my talk.
There, yeah, sorry. All right. As long as it advances the slides, we're good. Normally, when we see something like this, in sort of regular medicine, he probably, he would be put on a statin, right? So with hypertension, LDL of 133, high triglycerides, stuff like that. But he didn't want to do that, which was fine with me. And he said, okay, he was committed to trying lifestyle. So we discussed cleaning up his diet, more low carb, high fat, and arrange follow-up in 3 to 6 months. So he came back 2 years later. So that's also real life, right? So, okay. And I didn't change the age of this. The age was during part of, I think, when he presented. He actually had lost 20 pounds. Blood pressure was improved. He'd been doing intermittent fasting, ate at 2 p.m. And then again in the evening. He was an alcoholic. He was still an alcoholic. Drank huge amounts of alcohol, and never started exercising. So this is diet only, these changes. What's really interesting about this, his triglycerides, went from 205 to 132. I like to be below 70, so it's still too high as far as I'm concerned. His HDL, 47 to 91. I mean, this is diet only, and I see that a lot. It's the saturated fat that does it. And, most docs, we'll see, I have patients who come in with HDLs of 20s and stuff like that, and I can get them up above 60 easily, with diet, which if you talk to most people, they don't think it can be done.
And do you use additional fats, or just have them switch to red meat?
Basically, he had a high-fat, low-carb diet and did intermittent fasting.
Do you know what his fats were?
No. He had, well, I do, I just don't remember. It was sort of a regimented kind of diet. Every day, he ate the same thing.
I just wondered with patients I've struggled with getting their HDL up to 170, I can get up to the 50s and the 60s, but I've wondered if just getting, like you said, people are phobic about eating fat.
Right.
I'm happy adding sour cream and a pound of butter a day or whatever, but not everybody's happy to do that. Not really. But will red meat alone do that, or do you really have to add extra fat?
Red meat typically by itself won't do it. Yeah, butter and bacon seems to be very popular in my patient population. Butter and bacon.
Butter and bacon.
Butter and bacon.
It's awesome.
Butter and bacon, yeah.
If you look at just like as a strict, metric, you actually improved his,
Oh yeah,
LDL, C
yeah.
is down.
It's LDL. This is not necessarily a typical result for me for LDL. My patients' LDLs will often go up.
Right.
But
and even their particle count can go up
yes,
significantly.
yes, and I do have one later like that. This guy was just amazing, Now we have two different labs here, so it may not be completely the same from one to the other. But this is, these are pretty impressive results. My panel contains ferritins, the one I usually do, so I get a lot of high ferritins, and I'm doing a lot of these hemochromatosis genetic tests and stuff like that, and I've significantly increased the blood pool of Northern Virginia because I keep sending people out to donate blood to get their ferritins down. But
what's your target for ferritin?
100. So, whatever's reasonable. These numbers, the other thing people don't realize, I do so many of these numbers jump around a lot. So you can't be too picky about, getting them in. I think this is a problem with some of the functional medicine docs is they try to get in too narrow a range. And you can't, you check it. Sometimes we send labs by accident to two different, same specimen to two different labs, and they're always different. And you have to be really careful to overinterpret results. So,
How much do you worry about the quality of the red meat? Grass-fed, grass-finished, the bacon. Do you talk a lot about that, or you just?
Well, not initially. A guy like this, who's drinking like a gallon of vodka a day or something like that, I'm just glad that we got this. Again, we have to be realistic.
Did you include liver function tests?
Yes, I did. His liver functions were normal, but I don't have them here. Yeah.
Saturated
Normal.
fat is protecting his liver.
Yeah, it is now, right? Yeah, yeah. If it were abnormal, I would have put it in here.
But
Yeah.
don't you routinely get particle number instead of just cholesterol levels?
I do, yes.
That would be more important to see then. LDL cholesterol is relative.
Well, the particle numbers is in here. Do you see it, right? It's right here.
Move up closer.
So it went from 1594 to 798. So yes, yeah, it's a huge change.
That's like the most important change there.
Yeah.
Other than is.
I don't, you know what? I'm not as hung up. I do all these things. I'm not as hung up on particle numbers, frankly. I'm not that excited about it anymore. The triglycerides and the HDL for me are more important because, and I was telling Rick, last year I talked about metabolic syndrome and panels available for that, because I think metabolic syndrome is more important, which is what all of you guys have been really saying today or yesterday. But these are just, for me, I could do the regular lipid panel and know what it shows. And part of the point of this is that this guy saw this 2 years ago and sees this now, okay? And he's like, whoa, I went from red to green. I'm doing something right, but I still have a yellow in there, and if we went further into his thing, there's other yellows and reds, and he's like, I want to be all green. So he's going to work on this, and so we are actually, I'm working with him now, well actually I'm sort of getting ahead of myself, because this is his CIMT. For those of you that don't know what CIMTs are, it's a carotid ultrasound where it's looking at the thickness of the vessel wall. And in this particular, 1.3 millimeters or greater is considered plaque. This is the after CIMT. His average mean CIMT, or IMT of the common carotid, is what gives you your arterial age. So you look, his arterial age is 10 years younger than he is. He does have plaque. The other thing that's really interesting about this is the reason he came in the first place is because they saw plaque in his carotid Dopplers, So I'm not sure what's going on here, because a tiny little 1.4 millimeter plaque should not have shown up on a Doppler. So either we had plaque regression, which I'm not sure I believe exists, true, or somebody made a mistake somewhere along the line.
Jasmine, so the bottom is plaque on this report, plaque burden.
Plaque burden.
Not thickness, but.
So these are the maximum. These are the maximum readings in each region.
For the intima.
For the intima, right. And then, so the common carotid is the one that's used in all the cardiology studies to do carotid age, to do arterial age and risk. But most of the companies who do this will give you readings in all regions to sort of give you an idea of what else is going on.
I'm just a little confused by that report, because I think it's just important to recognize that intima is the lining.
Right.
Okay, and that's not the plaque in the lumen. And I think your report is showing plaque in the lumen.
But plaque starts out under the intima, doesn't it?
Right.
It's two different.
Well, I think it's the thickness of the entire vessel wall. Not.
Our sonographer, I talked to her, intima is measured separate than plaque. And so there's two components to that.
So in this
So
case.
what we do is we get a CIMT with a limited Doppler. The limited Doppler looks at the plaque in the lumen, and I think.
Well, the limited Doppler will give you stenosis.
Yeah.
Right. This doesn't even do that. This doesn't tell you whether or not you have stenosis.
Plaque burden, so
Yeah.
that's not showing you.
Stenosis, no. And something like this would not show. He would have no stenosis with an amount that
Just in
small.
our office, so we actually
Yeah.
do a
Right.
limited Doppler.
Actually, I have a new company doing it too, and they do a full carotid Doppler along
so
with the
cool.
CIMT now.
I think they're
So,
both important.
yeah. So, anyway, sort of running out of time, right?
You kind of are, but this has been wonderful. We have 10 minutes.
Okay, because I have two more cases, but well, I'll go. We don't have to go through all of them. Okay, so this is a new patient who came in last spring. He sought me out because he had been treated with a statin. His previous physician had stopped it because his liver function tests had gone up. I have questions whether it was the statin that was that or something else, but he wanted to try lifestyle management to control this, and had already begun to work on some by exercising and being more careful with his diet, which was lots of grains and fruits, but he was doing less processed foods and just being healthier overall. He has a family history of early cardiovascular disease and diabetes. So if you look at the readings on the top and on the right were the ones he came in with when he was on the simvastatin. And then of course, he went off the simvastatin, and his doctor went nuts because his LDL went from 140 to 273, you know. But if you look at his HDL and his triglycerides, they were actually significantly improved. So this is an interesting case because his ferritin was 1170 too. Yeah, and his genetics for hemochromatosis were negative. Now, there may be other mutations, but, you know, we do what we have access to. So you know, what can you do with somebody like this? So we did do the diet. You know, we cleaned up his diet. Whoops, wrong page here. So he did about 5 months of a low carb, high fat ancestral diet. He lost 28 pounds. But what's really interesting about this, you know, his total cholesterol went up, which, you know, most people would go nuts on. His LDL went up a little bit, but his particle number actually went down, Bob. So, you know, I don't know how high it was before because he sort of timed out. His small particles went down. His HDL improved further, and his triglycerides improved a little bit further also. So I sent him for a couple of blood donations. He had 2.2 pints taken off, and his ferritin dropped from 1170 to 613. Now, I do this a fair amount. This is not just 2 pints of blood. You know, this is an improvement. Ferritin is is an inflammatory marker, and that obviously improved.
Yeah, just a quick question with the ferritin. So it's obviously an inflammatory marker. It's a symptom of something else
Right.
going on by phlebotomizing them. Is that
Yeah,
therapeutic?
well,
or is it just, you know,
I don't
the
know.
looks better and then
I don't know. You know, blood drawing is a good thing. It helps a lot of people. They love really iron-rich blood. We might as well just give it to them. You know, you have them draw some blood. Their ferritin goes down. Maybe we're helping them. You know, maybe it protects the liver. Who knows?
There is one study, it's an epidemiologic study that shows that blood donors have much lower cardiovascular risk, normalizing for all other factors, all other risk factors.
It's important to check though, my ferritin went down to 11, I had to stop giving blood, and I was still acceptable to
But
the
you
blood.
didn't start off at 1100. You know? So, yeah.
But you just can't be a
are you
good
treating the
American.
number or
What's
are you
that?
treating the number or is it really
I am treating a number, yes. But you know, again, you know, I'm practical. You know, I'm in the trenches, family practice. You know, I don't. I have to treat these people today. I can't wait till the studies come out, and some of these studies will never come out, right? So,
But
it's
ferritin isn't just a marker of inflammation. It's a marker of iron overload. And
Right.
Iron overload is a risk factor for coronary
Right.
vascular disease.
So they
And
were-
phlebotomy is an acceptable treatment.
so the iron overload is because of their diet? They're eating more red meat, you think, or
It's
No.
related to diet plus interaction with your
No.
SNP.
no. This guy's eating more red meat than he did before, right? And his ferritin went down significantly. Well, only 2 units. 2 units will not do that. You know, over a 5-month period. So yeah.
Because iron deficiency mimics ADHD and also depression, I do ferritins on everyone who walks in my office. Well, the way I kind of help to balance that is I just go ahead and do a CRP, a C-reactive protein. And if the C-reactive protein is okay, then I assume the ferritin is true.
I don't know that you can. I have CRPs on all of these people.
Yeah.
Yeah. I mean, this guy has got high. I didn't put it on here, but he's got high inflammation. You know, he's got some inflammation, obviously, but yeah. But I don't know that you can assume that. What's that?
You've written there his LFTs are also normal.
Yes. Now his LFTs are normal, which is interesting. Yeah. So. Yeah.
Which one intervention we don't know.
Right.
Treated it.
Well, yeah, right. We treated multiple things, and I have like I have metabolic panels on all these people too. If it didn't really show much, I didn't really. That's why I didn't put them in. He had a CIMT also, and he also has plaque. He does have what they call soft plaque in the bulb. I don't know how reliable that is, but they always call me up when they find soft plaque, so they must think it's important. So, but you know, we are, you know, I mean, so a guy like this, if he were to have an event, you know, that could spelled trouble for me since he's not on a statin. He didn't want to go on a statin. I documented that. I mean, and this is part of the, this is where we as physicians have to have courage, because the risk of event in this guy is still quite high. And, by not insisting that he try more medications, I'm leaving myself vulnerable, and if an event were to occur, I documented that he didn't want to be on a medication, encouraged him to keep trying. He's very motivated at this point. We're doing blood work every 3 to 6 months and CIMTs annually to follow this. So, okay.
There are supplements too that can lower your LDL cholesterol. I don't know if it would help to say you try those while you're on the way to thinking about it.
Yeah, I don't know if it's worth doing another one of these guys since I'm basically out of time. I'm trying to think. There was something interesting about this one.
Just show us the results.
There we go. So this one had less. He's early, 3 months diet. HDL. I mean, 36 is still really bad, but it's a 25% increase in HDL, which, if you tell it to a cardiologist, they're like, oh, no statin can even do that, right? So, the triglycerides dropped tremendously. Particle number, here's one of the ones. This is what I want to show you. Particle numbers did go up. So, and the small dents are about the same. But still, again, dietary management and then inflammatory markers here, I'll put some in there, trending downward. But I use this data to kind of help, like I said, help convince patients to do to be more compliant, to do what they need to do. I don't need this data. I know what it's going to show. But this, people say it's expensive, whatever, but for me, it's a very good motivating tool, and I get way more out of these people than I would otherwise. No question about it. So.